Welcome and thank you for coming to today's presentation. This is our webinar series called the Sight and Sound Bites. It's brought to you by the Eye and Ear Foundation. My name is Craig Smith and I'm a development officer with the foundation. This bi-weekly webinar series highlights research in the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. This research is only possible thanks to generous philanthropic support, so we want to thank everybody who has supported us so far. I want to go over a few housekeeping things for today. For these webinars, we do disable the chat function. However, you can submit questions for our presenter through the Q&A function at the bottom. And after the presentation, we'll answer those questions for you. We do ask that you refrain from asking very personal questions that may not be relevant to the broader audience. However, we'll try to answer those questions offline and get back to you after the program. As always, you can also send additional questions to me through my email, which is just craig@eyeandear.org. We've also enabled captioning for this program, so please feel free to use subtitles as you follow along. And we are recording this program and we'll be adding it to our website with our other webinars afterwards. So if you're not able to view it all, or if you'd like to view it again or share it with friends or family, please feel free to access that on our website, which is just eyeandear.org. Additionally, everybody who's attending today will be added to our mailing list if you're not already, so that you can receive periodic updates on various research taking place within the departments through our blogs, newsletters, and webinar invitations. Today's presentation is titled, "It's a Hard Pill to Swallow, Understanding the Difficulties of Swallowing from a Physician's Perspective." I'm joined by one of our newest faculty members, Dr. Sandra Stinnett. Dr. Stinnett is an assistant professor of otolaryngology at the University of Pittsburgh, the director of the Swallow Center, and a member of the UPMC Voice Center. And I'd like to turn it over to her at this time. So, Dr. Stinnett.
Thank you so much, and thank you for having me today. I'm really excited to talk about a topic that a lot of clinicians find very challenging to treat for reasons that I will discuss shortly, but I really have enjoyed diving a bit deeper into the world of swallowing. There is a lot to kind of investigate in this clinical aspect of ear, nose, and throat. And because I just got here about a year ago, I'm still kind of getting my feet wet in the research realm and trying to figure out how to navigate it. But having some ideas that I definitely would like to share and discuss with you today in regards to dysphagia and some future implications for possible research opportunities. So I have a disclosure for Cook Medical. I'm a consultant for one of their new dilation balloons that I use. And so we'll talk about the definitions of dysphagia as it pertains to swallowing, normal and abnormal swallowing mechanisms, some of the common causes of swallowing difficulties, and some common diagnoses, as well as the workup and then the management of dysphagia. And so we don't really think about it. Many of us don't really suffer from swallowing difficulties, but it's definitely a quality of life issue that impacts us on multiple levels, both culturally. Oftentimes when we have meetings, we like to do it over food or do like a lunch webinar like we're doing today, family gatherings. Pretty much most of our culture revolves around food. And so I've had patients that canceled whole trips to Ireland because they don't want to be worrying about going out to eat and not being able to swallow. And luckily, we've been able to help a lot of these patients, and they are able to enjoy time with their families and enjoy the gatherings without being embarrassed. But for those that can't, it is challenging for them, and the clinician as well, because we want to try and help them as much as we can. And so dysphagia is a fancy way of just saying difficulty with swallowing. And it has to do with abnormalities that impact swallowing from the mouth all the way to the stomach. And swallowing is actually one of the most intricate and I think fascinating phenomenons of the human body, because much of it is quite involuntary. I mean, we don't really think about swallowing and how we're going to swallow this meal before we get the meal, right? Like we think about many other things and functions in life, like when we're going to go to the bathroom, or when we're going to go to sleep or anything like that. But swallowing, we can just kind of do it. And it's so well orchestrated and requires so much innervation and different pathways and pipelines that work in concert with each other. And so there's three, sometimes we break it up into 4 phases. And the oral or oropharyngeal, also here known as the buccal phase, is basically when the food goes into the mouth and we chew it up. And so we have to ensure that our teeth are in good shape, our tongue function is pretty good, our palatal function is pretty good, and that helps us to propel the food back past our tongue into our throat. And that brings us into the more involuntary component, the pharyngeal esophageal phase, part 1 and then part 2. So those phases just help to push the food down from our throat. We push them down. Our airway shuts off at the level of the vocal cords. We have a floppy epiglottis, which is a flap that just covers the throat, the airway part of the throat. And then the throat actually lifts up. If you swallow, you'll notice that your throat actually raises up and forward, and that opens up the food tube in addition to some passive relaxation of the muscle. That's the gatekeeper for the throat. And that brings the food down into the food tube or the esophagus. And then the esophagus actually has a series of contractions called peristalsis that brings the food back into the stomach. So all that happens in a matter of 20 seconds or so, which is incredible with solids or liquids. And if there's a deficit in any of those things, it could either result in a sensation of food getting stuck, food coming up back up in the throat, or food going into the airway. And there's multiple swallow centers in the brain that coordinate this with the vomiting centers, that coordinate this with the respiratory centers. So it's a pretty intricate pathway. And we swallow over 500 times a day, both consciously and sometimes unconsciously. Our body just tells us to swallow to manage the secretions as well. So there's just that alone is a phenomenon that we kind of understand, but fully the circuitry of it and the fine details are so complex that there's yet a lot to be understood. So the complexities of the oral and oropharyngeal phase, it requires so many things in concert at the same time. So tongue elevation, then your tongue moves back to the back of your throat, your palate elevates, and then your palate moves backwards to prevent food from coming out of your nose. Then the hyoid, which is a bone at the top of your neck, moves up and forward. That causes the whole larynx or the throat to move up and forward. And then that epiglottis, that floppy part, kind of just flops over your airway to protect your airway. And then the food goes down the hatch, which is amazing. And this happens again in seconds. So you can imagine, especially for us as ear, nose, and throat, swallowing is really important. And we work in concert with our GI colleagues to deal with the pathologies and the difficulties that patients face. But we're dealing with head and neck cancer patients as well that have, partial tongue excisions or cheek surgery or throat surgery that suffer tremendously from swallowing deficits. So one of the interesting parts for the esophageal phase after it goes into the throat that we as ear, nose, and throat doctors deal with is the gatekeeper, I like to refer it as, or the upper esophageal sphincter. And the main player in that is a muscle called the cricopharyngeus muscle. And so that's basically like the guard that opens up when the food is ready to go down into the food tube. But sometimes that guard is hypervigilant and you can't get food down that well. And so we have a little bit of overlap with our GI colleagues in managing everything from that sphincter down to about the upper part of the food tube. Everything else is a GI issue, which we collaborate with quite intimately nonetheless for patients that have dysphagia. So when I think about the food tube, I think about being a plumber in a way, because the deficits could be either structural, where there's a mechanical or an obstructive lesion that's not allowing the swallowing to work as effectively, or it could be functional. So there's either something stuck in the pipe or the pipe itself is not working well. So that would be the neurologic or the muscular component of it. And so based on certain parts that the patient may elicit we can glean, okay, this is more of a mechanical issue, or this is more of a neurologic issue, and that will lead us down a pathway for evaluation. So oropharyngeal is kind of the mouth and the back of the mouth. And deficits, sorry, it's broken up because I wanted you guys to see it, but it's one word. Difficulty initiating the swallow. So anything oral cavity, oropharyngeal, tongue weaknesses, tonsil surgery for tonsil cancer, things like that. Nasal cancer could result in some oropharyngeal swallowing issues. Functional, some patients just have a sensation of difficulty swallowing with no deficits from a muscle or nerve issue, and that could be stress. There's a really great TED talk by a speech language pathologist, I'm blanking on her name, but we as ear, nose, and throat doctors, particularly laryngologists, appreciate the validity in the fact that the larynx is an emotional organ. You know, sometimes, you know, you feel like you have a lump in your throat when you're nervous, or you feel like you can't swallow when, you know, you're stressed out, or you get short of breath when you are having stage fright or something like that, or your voice goes away. All things that contribute to a potential functional cause for swallowing. And that just speaks to the fact that the muscles that we use to speak, the muscles that we use to breathe in the throat, and the muscles that we use to swallow are all intricately involved. And so at any time, if there is an emotional impact, many people manifest those symptoms in the throat, and that may result in some swallowing difficulties too. Esophageal abnormalities, you know, like I talked about the gatekeeper or the peristaltic wave of pushing the food down, the food tube could be impacted in whatever capacity, and that could cause swallowing difficulty too. And food tube manifestations can sometimes be referred to the throat. So sometimes patients will say, oh, I feel it here, but really it could be something that's stuck down here, whatever the cause that is. You know, the nerves overlap quite a bit, so it may manifest as symptoms in the throat when it's really occurring down here. And then neuromuscular, such as stroke or any brain damage, could cause swallow symptoms and deficits as well. So patients that have dysphagia may feel pain or difficulty with swallowing, sensation of food getting stuck in the throat. They may cough or gag if it goes down the wrong pipe, if it goes down the airway pipe instead of the food pipe. That may cause them to gag. They may have some nasal regurgitation. If you are a patient that has a history of radiation or a nerve deficit in the level of the palate, the roof of the mouth, and the back of the throat, and you can't get a good seal to close off the back of the throat, that may cause food to come out of the nose too, which is embarrassing, but it also creates a weakness to get the food down because you need that seal up top to generate pressure to push the food down in the throat. Difficulty speaking can manifest in conjunction with difficulty swallowing, and that could be an indication of a neurologic issue. Nasal speech goes hand with the nasal regurgitation and palate deficits. Some heartburn could be indication of either a deficit at the level of the sphincter, the gatekeeper at the top of the throat, or the food tube itself, and a weakness in pushing the food down. Acid brash, or food getting stuck in the throat, or unintentional weight loss. But very important, you know, those symptoms are important, but things that we can't afford to miss are swallowing symptoms that are so severe that patients require either the Heimlich maneuver, or they have episode of aspiration pneumonia, which can be life-threatening, or even failure to thrive. They're just losing so much weight that they are not able to sustain and are suffering significant other comorbidities as a result. Those patients we need to be very careful for and diligent with, and may consider other options for nutrition, including enteral or a feeding tube. So some examples of mechanical or obstructive I've listed here. You know, for us, for ear, nose, and throat, common things are the post-surgical head and neck cancer patients that may or may not have undergone radiation. Foreign bodies, we see patients that come in and, you know, their kids may have swallowed a coin or something, or battery, which is also an emergency. But things that we don't really ear, nose, and throat may not really consider because we're so head and neck cancer heavy, are other esophageal etiologies, such as external compression onto the food tube from a tumor or a mass in the chest, or a pouch in the food tube itself. Strictures as well could cause some obstruction that we could also address. And esophagitis. Sometimes patients have an esophagitis that can cause food impaction, and treatment for that is pretty easy with swallowing steroid inhalers to mitigate that. Other things that can cause neuromuscular etiologies for dysphagia, so are neurologic causes such as myasthenia gravis, multiple sclerosis, other myopathies or muscle deficits, rheumatologic diseases, autoimmune diseases like scleroderma can result in dysphagia, spasms, and even echolalia, which can have an infectious cause too. And so we, in building the Swallow Center, our referral base is very head and neck cancer heavy, but we're establishing rapport with our GI colleagues and our neuro colleagues in order to kind of help facilitate swallowing in a multidisciplinary approach, and including our speech language pathology colleagues as well. And we'll talk about that a little bit more. So I thought this was interesting to kind of show you guys the visualization of what foreign bodies that I've seen in my career and in my training, and I'm sure most of my colleagues have seen too. So this is just an X-ray. Patients come in quite a bit with foreign body sensation, and sometimes parents or people may witness it, but you start off with a chest X-ray and you may see what the culprit is. And this is just a child that swallowed a coin. And you can see we took them to the operating room, and there's the coin on the exam in the food tube. This is a child that swallowed a Mickey Mouse toy. And that's interesting to see on an X-ray. This is a child that actually swallowed the bubble, the things that you blow bubbles with, the wand. And you could see the little circular wand there. This is a patient, I've actually seen this in residency, that swallowed a denture. And so, they're missing their dentures and they actually wound up swallowing it, which is kind of interesting. Also have seen fishbone. So you can see a fishbone getting impacted into the swallow tube there. And then a toothbrush. I don't have an explanation, and I have never seen that before, but I thought that was interesting. But yes, I've seen a fork before. A patient swallowed a fork, but I've never seen a toothbrush. So you never know what you're going to get, but these can certainly cause swallowing issues, and you want to get them out as soon as possible. And so, we involve all of our colleagues from all disciplines to join us in collaborating to kind of make dysphagia and improve the management and treatment of dysphagia for our patients. And so thoracics, GI, ENT, and our SLP colleagues, we work hand in hand. Emergency medicine for foreign bodies, oncology for our cancer patients, rheumatology, and neurology are all specialties that do see dysphagia patients as well. And so I call the esophagus the goose. And we have extensive tools in order to kind of figure out what the culprit of the swallowing deficit is, including quality of life questionnaires that have been validated. So EAT-10 is one. We also use the RSI, which is looking at reflux severity. The exams that we do as ear, nose, and throat doctors regularly is flexible laryngoscopy to look at the vocal folds, to look at the top of the food tube to kind of see if there's any abnormal masses or lesions or any obvious findings. You could do a flexible endoscopic evaluation of swallow, which we do in the swallow clinic pretty regularly, where we look with the camera through the nose to look at the throat while the patient is swallowing various consistencies and different types of foods that's colored blue. Sensory testing, we don't really do that as much, but you can kind of check to see if the patient is even able to register that there is food in the throat. Is it going in the right way? Are they coughing if it's not going in the right way? And my enjoyment is transnasal esophagoscopies, where kind of like the exam where we look at the vocal folds in clinic, we can now look at the food tube. So we pass the camera through the nose. kind of like the EGD that the GIs do with a smaller scope, and we are able to pass it through the food tube down to the level of the stomach. And then another modality that we use, and it's formally done by our colleagues in GI, is high resolution manometry. And that basically just gives us an idea of the pressure gradients of how the food tube is able to push the food down via peristalsis, and if there's any abnormal pressure gradients or pressure being generated by different parts of the food tube, and helping with diagnosis. And so these are just the paradigm that we use quite frequently, and it's kind of long because you got the patient coming in for initial visit, and then now gratefully we can do the transnasal esophagoscopy and look at the food tube in clinic, and do the flexible laryngoscopy. We could do the fees, looking at them and seeing how they swallow in clinic. But then if we want further testing, we have to do the video swallow and then refer to GI and then do a biopsy and, do all these other tests that may require 4 or 5 visits, all very pertinent and important. But now it's streamlined by the transnasal esophagoscopy, because oftentimes when the patient comes in for initial visit, we can do diagnostics and sometimes therapeutic interventions simultaneously. And so, it's great because we could, what once took weeks to schedule an intraoperative procedure to dilate and biopsy, the food tube and stretch the food tube, or even just a simple exam under anesthesia, we can do in clinic now. And so it could be a one-stop shop in treating and diagnosing the patient, which is cost effective. It saves time for the patient. They could literally come in. Oftentimes I don't use any general anesthesia at all. I don't even use any anesthesia to take the edge off at all. Patients tolerate it pretty well with just a topical anesthetic. And they can go back to work afterwards. And so this has been quite the game changer in regards to diagnosing and treating in a timely fashion, and also cost effective. And so I really like dysphagia because the patients feel immediate gratification oftentimes. And even if it is delayed gratification, where we require more of therapeutic interventions from a speech pathology standpoint, you're making a difference in the patient's life where they feel like sometimes they're cancer free and they're still, not happy because they're cancer free, but their quality of life has deteriorated so much. And so there's so much that we can do. And there's so much coming down the pipelines from a research standpoint that we can contribute to in order to improve these patients, whether it's cancer or even, stroke patients, from a swallowing standpoint. So hard work doesn't mean success. It does take a lot of hard work, and I'm really excited to contribute to the Swallow Center in that way. But I think it also requires passion and realizing that it makes a difference. I just had a patient today in the VA that was just tremendously frustrated because they're choking on the saliva and got really upset, at me, but not directed towards me, but just frustrated because they didn't have a solution. And it was a breath of fresh air when I could offer them some interventions that were not tried before, and his body posture changed. And those are the wins for me. And so if we could do that on a larger scale and be recognized as an institution that can provide that for patients that don't know that patients that aren't aware that this exists as an opportunity or an option for them, then that would be a win. So I'm excited to collaborate with Tamara Winko and Dr. Jonas Johnson on, building and growing the Swallow Center. So there's a number of papers that are coming out as well to address these issues. And we know that it's a quality of life issue that's evidence-based. But some of the things that I am excited about are head and neck cancer patients and how they're dealing with the sequela of interventions for treatment for head and neck cancer. And so there's trials that are implementing prophylactic swallow therapy or interventions prior to the interventions for the head and neck cancer, so that they're ahead of the ball and not just getting, therapies or interventions after they're dealing with the sequela of the head and neck cancer treatment. And so that's been proven promising for dysphagia outcomes, because dysphagia outcomes significantly impact the gestalt view of the head and neck cancer patient, regardless of whether or not the cancer is cleared. If the patient's swallowing symptoms are significant, then it could have deleterious effects on the post treatment outcomes as well. Another thing too that's really interesting to me is the unnecessary feeding tube placement that a lot of patients in the hospital undergo. It's been studied extensively, I want to say, in the pediatric literature. This is a new paper that came out just this year on the quality and patient safety from the Joint Commission, looking at unnecessary gastrostomy tube placement in hospitalized patients of all etiologies. I think most of it was stroke related, but there's also interventions. There's also literature to support that patients that have dysphagia while they're in patient hospital stay oftentimes get feeding tubes placed before they are, rehabilitated and less deconditioned. And if we focus on rehabilitating them to a better place instead of rushing to feeding tube placement, oftentimes they don't need a feeding tube, which is big, because a lot of patients don't want a feeding tube. And if we're unnecessarily putting a feeding tube in so that we can get them to rehab faster, or because we're concerned about pneumonia, instead of getting multidisciplinary approach with speech pathology on board and maybe doing some therapy in-house to mitigate the need for gastrostomy tube placement, I think that can go a long way. And I'm glad that the Joint Commission is actually looking into that. And this, like I said, is a prelim study. And that's something that we could certainly be looking at and tackling in our own institution. And also, office-based dysphagia management is becoming more and more common. And this is our colleagues just, down the highway in Ohio, Dr. Howell and Dr. Casola, that have done great work looking at office-based dilation in head and neck cancer patients. And myself, I've even had patients express anecdotally that the awake stretching of the food tube has lasted longer than the intraoperative procedures under general anesthesia, which is great because we're not requiring general anesthesia for these patients that may have multiple comorbidities, and we want to reduce the risk of anesthesia exposure. And we're also not impacting their quality of life by having them come to get these repeat procedures with general anesthesia every 1 to 3 to 6 months. And so I'm really excited to dive deeper into that and kind of prove like, hey, this is a modality that should be widely accepted, and we can offer these services to our patients and make a big difference. And so just some studies that, I feel like are scratching the surface, and we just need to do more and make it standardized care. So office-based procedures is my claim to fame. I love laryngology because of that. It's quick. It's, I wouldn't say easy. It's easy for me as a clinician because I just have to do the job. I think the hard part is coaching the patient, and actually the patient is what makes it easy for me. So if I'm able to adequately prepare the patient for them to allow me to inject their throat while they're awake, or put a balloon in their food tube while they're awake, or inject their palate while they're awake, then I win and they win ultimately, which is the goal. And so office-based procedure patients that have challenging anatomy, oftentimes our intraoperative procedures require significant neck extension. Some patients don't have that because they have cervical spine disease. And so those patients are great candidates for office-based procedures. If they're really sick and they can't undergo general anesthesia, if the patient prefers, they're busy, they're working, they want to come in, come out, get it done. If the benefits, we can diagnose and treat, there's less downtime for the patient. And as a surgeon and post-COVID world, we're still dealing with OR time issues. And so if I'm able to do something in the office and mitigate a 4 to 6 week wait, I can do it next week in the office, or I could do it right now, and oftentimes get patients in quicker that way. So this is a video just showing, let me move my, an injection of the vocal cord. So in the clinic, you have the patient just in front of you, and it requires a second set of hands, either to put the camera in the nose, or this was my fellowship attending, or you could hold the camera in one hand while you're injecting with the other, while somebody else holds the tongue for you. And this is just a cannula that we use to access the vocal cords. And for patients that have vocal fold paralysis, we can inject a filler to fill up the vocal fold that is not moving as well. And it certainly has an impact on the voice, because the voice becomes more breathy because the vocal cords are not closing as well. But in addition to that, there's a gap in the windpipe. And so some patients oftentimes complain of difficulty swallowing and aspirating. So you could inject the vocal cords, and that can oftentimes provide some relief from an aspiration standpoint. And so this is just a video showing the needle, and it's incredible. The patient's awake, it's breathing. It's kind of like a video game. You're working on a moving target. And then we inject a filler into the side of the vocal fold, and it plumps it up. You could see it plumping up the vocal fold here. So you'll see that it'll get better closure, which produces a louder voice, but it also produces better airway protection during swallowing. So patients don't choke that much on their food or their liquids as much. And yeah, and patients go home. The only restriction is don't eat or drink for an hour or two, because you're numb. We numb with some nebulized lidocaine, and we drip some lidocaine on the vocal cords as well. And this is it. I think maybe like 10 minutes prep, and maybe the procedure itself, and then 5 minutes afterwards to just make sure they have their bearings after the procedure. And that, like I said, this procedure lasts about, the gel lasts about a month. There's longer acting injections that we can use that last about a year. But for the patient that we know is having a lot of difficulty and the vocal cord isn't moving, and we know that the function's not really going to come back, we can do, this is a surgical procedure for those of you who may not want to watch. We can do a medialization thyroplasty. And again, this is another awake procedure. We don't do this in the clinic. We do this in the operating room. But again, the patient's awake, and we make a cut through the neck and access the vocal fold through the cartilage. While we're in the vocal fold, you can see the light there. We take the camera through the nose and make sure we're in the proper position. And then we use a Gore-Tex implant, which we use for cardiac surgery as well. And we just basically place the implant through that hole in the neck, into the vocal fold. And it pushes the vocal fold like it did in the video before, like the injection in the midline.
There you go. Does that feel better? It's deeper.
Taxi.
Taxi. Very good.
And you just confirm that the voice is improved, that they're breathing okay. You can't test swallowing at that time, but oftentimes if the voice is improved and if they had any swallowing issues, then the swallowing would have improved too. So that's one of my favorite surgeries. This is a procedure. This is an office dilation on an awake patient. And so it does require special equipment to do. And these are just some of my residents working with me. So you need somebody to drive the scope, somebody to drive the balloon, and somebody to insufflate the balloon. And you can see the esophagus here on the screen. So we're passing the camera through the esophagus, and then we pass a guide wire through the camera, and the guide wire is in the esophagus, and we pull the camera out, and then we put a balloon over the guide wire while we're seeing the the balloon in the esophagus in the back of the throat. And then we inflate, and the patients tolerate it really well. You could see the airway, you could see the balloon inflating, and that is the area where that gatekeeper I was talking about is. And you monitor the patient's airway. Oftentimes they feel like the airway is going to close, just because everything's pushing forward from the food tube into the airway, but we have direct visualization. And so rarely is the airway compromised in that way. If the balloon flips, for whatever reason and causes some obstruction transiently, you could just pull it out. So it's safety wise, it's a pretty safe procedure. And then another thing we talked about with the food coming through the nose, which a lot of the radiated patients suffer from, it's velopharyngeal insufficiency. It's what it's called. It causes the nasal regurgitation. We can inject some of that filler into the back wall so that the palate that's here touches the back wall and prevents food from regurgitating back up into the nose here like that. And so this is a video. This is a camera through the nose and then the injector through the mouth. And patients tolerate it really well. You'd be surprised. I think a lot of coaching goes a long way. I kind of undersell it and over deliver and tell them it's terrible. You know, it doesn't feel really good. And this is what you may feel. You may feel like you want to throw up. It wouldn't be the first, you know, just to make them comfortable with the fact that the possibilities of throwing up or even not being able to tolerate the procedure. Luckily, fingers crossed, I have not had to abort a procedure. Patients pretty much are ready and willing. And especially with our head and neck cancer patients, they've been through so much already. I feel like this pales in comparison. And so they're willing to really undergo these procedures and just go about their daily life. And so you could see this is the palate there. And that's the palate closing into the back wall. You see there's a little bit of a deficit still there. You can see some of the liquid kind of seeping through there. But in theory, you may want to inject that area a little bit more to prevent the food from regurgitating over into the nose. And so I'm really excited to have joined UPMC and particularly working with Tamara Winko. It's been such an awesome pleasure to kind of, you know, build up the Swallow Disorder Center and collaborating with amazing colleagues. My GI colleagues have been super supportive, and I've been doing a lot of my awake procedures in the GI lab just for ease and equipment purposes. And our thoracics colleagues have also been super supportive as well. Tamara Winko has built up such a solid team of speech language pathologists for both inpatient and outpatient. It makes a significant difference in the survivorship and the cancer care, but also outside of head and neck cancer for the neurology patients, the neurosurgery patients, rheumatology patients, ortho spine patients. You know, they get the care that they need and deserve. And so it's kind of grateful to be able to walk into a system that works really well and that they know what they're doing and just to make it go up from there. And the exciting part too is that there's not a lot of research that's going on, especially as it pertains to these office-based procedures and outcomes. And so looking forward to investigating that further, multi-institutional wise, looking at some office-based comparisons and disparities research. I think in laryngology, and unfortunately, we do not have a lot of strong research in disparities. And so, you know, the stage is set for us to kind of capture that arena as well. And the School of Public Health has been very supportive in that. And we look forward to working with them as well. Already working on some local, regional, national, international collaborations for standardizations of protocols. You know, we just came out with a action statement for how we should make our swallow studies standardized, which is mind-boggling. It's 2022. We've been doing swallow studies for so long, and only recently have we come out with a position statement as a subspecialty on how best to perform and execute the swallow studies. And so that's the tip of the iceberg. There's still more work to be done, more standardizations to be done. And we've already been collaborating with some local folks in that regard to perform and create more standardized protocols. We're also working on some courses for our clinicians, speech language pathologists and laryngologists, as it relates to transnasal esophagoscopies and laryngoscopies for speech therapists in performing the swallow studies. Multi-institutional research initiatives and collaborating with pharma, but also outside of pharma, we hope to do that, and also looking at some prospective studies as well. And so, you know, it's rewarding to make an impact on an individual basis with patients and swallowing, and just being the ears and the hands that could help and treat the patient. But we're also looking forward to collaborating and making bigger impacts through research collaborations as well. And so we have Tamara Winka, who I mentioned before, who's director of SEC. She's also director of the speech language pathology group there. Myself, who was just recently appointed as the director of the Swallow Disorder Center. So I'm really excited about that. And of course, Dr. Johnson, who has leveraged the Swallow Center and collaborating with the Survivorship Clinic and working with the head and neck cancer patient population, and has been doing great things for the past few years with that as well. And so I thank y'all for your time. I hope that, swallowing, it's hard to get people excited about, and people are always kind of fascinated by my excitement for it. But, I feel like we're in the right place and we're positioned to really make a difference with our head and neck cancer, our neurology patients, our GI patients, and really collaborating with the great minds that we have at this institution to spearhead that. So thank you. And if you have any questions, you can email me anytime as well. And those are my sons.
Well, thank you very much, Dr. Stinnett. That was a ton of great information about the swallowing center and everything that you're doing with dysphagia. We do have quite a bit of questions already, so we're going to jump right into it. The first question we have is, what is the role of dementia in dysphagia? Can somebody forget how to swallow?
Yeah, that's a good question. So there is a role for, I would say, many neurologic manifestations for dysphagia, and dementia is one of them. I wouldn't say it's a forgetfulness about swallowing, but it may be the functional portions of the brain certainly impact swallowing on a frontal lobe cortical level. But also coordination can be impacted by the dementia, which coordination for swallowing is super important. There are also, if we're looking at dementia as it pertains to like Alzheimer's or Parkinsonian dementia, there is data that does show that dysphagia or swallowing difficulties are very prevalent in those patient populations. And oftentimes treatment for that could be therapy. But, it's important to get a swallow study. And the other component is with age, you can get what we call presbyesophagus, which is like a nebulous term that just says the esophagus of, with age could be a little bit weakened and discoordinated as well. But yeah, therapy can oftentimes help with that, and just kind of isolating the cause, because again, we need to get a swallow study to kind of help us determine where the deficit is and what are the exercises, if any, that can be implemented. And surgery rarely, but if surgery is indicated, then we can address that as well.
So the next question, you talked about swallowing kind of being an emotional part of the human body. So this question says, how do you treat a patient who's convinced that they have a swallowing issue when in reality there is no problem? Does anxiety or mental illness play a factor, and can meds help with those issues that can actually help swallowing?
Very good question. I think this is such an interesting topic. And there's a debate out there about, there's an entity from voice called muscle tension dysphonia, where you kind of squeeze the voice box inadvertently out of proportion to what is necessary to generate voice. And you can imagine if you're squeezing, tight, you get a cramp. And so the cramp can manifest as either swallowing difficulties or what we call globus, a sensation of something stuck in the throat. And you may not find anything physiologically wrong that you could actually put your finger on and diagnose. But it's oftentimes a diagnosis of exclusion. And muscle tension dysphonia can cause muscle tension dysphagia, which is the difficulty swallowing component of it. And if it is, caused by stress or anxiety or depression, oftentimes you want to treat the underlying cause. Getting a patient to admit to an underlying psychological cause for a symptom that they feel is challenging. And so it requires like a certain level of finesse to kind of navigate that with the patient. Some institutions have a true multidisciplinary dysphagia approach where they do have a psychologist or a psychiatrist on board. And so that's a little bit easier than saying, I'm going to send you a referral to psych. So on the front end, as a clinician, I will do my due diligence to work it up because you don't want to miss anything that is true, like a true anatomical or structural deficit or a physiological deficit before you diagnose it as functional. So we'll get the swallow test and things like that. And then some things that we do outside of, a quick psych referral would be speech language pathology for management of muscle tension dysphagia. And oftentimes they do either physical therapy or the therapist for speech themselves will do what we call myofascial releases, which will help the tension in the neck muscles. And to be honest with you, our therapists are so good and they spend a lot of time with these patients. They're often able to glean, all right, what are you dealing with? Is there anything going on with work? Or, they tap into that sometimes. And that could be a segue where we could facilitate a psych eval or even just the manipulations themselves work. And so medication, yeah, but we wouldn't be the ones to do it. It would be the psychiatrist or psychotherapist to initiate any treatment as it pertains to the anxiety directly. But for us ourselves, the functional or, physiologic manifestations of it, we can address that and then facilitate that care if that was the case. But it's challenging because some patients get mad if you say, oh, well, maybe there's nothing there. Maybe we should consider. So we have to tread lightly on the way that we navigate that space. So, but it is there. It's real.
Thank you. So I do see a question here that's pretty specific. So I just want to let that person know that we're going to answer this offline. We'll send it to Dr. Stinnett to answer, and then we'll email you back an answer to that. So please don't think that we're not getting to your question. We will offline. So the next question I want to address is, does drinking alcohol reduce our ability to swallow correctly?
That's a good question. That's a loaded question. It can. It depends. I guess if you're drinking or consuming significant amount of alcohol, of course, there's an inhibition that occurs that can result in discoordination in every capacity, in the way that we walk, in the way that we function in general. There's also the dehydration component. It's a diuretic in theory, right? So if you're drinking a lot of alcohol and then becoming dehydrated, sometimes there is like manifestations of significant alcohol consumption that can result in esophageal issues like varices. That can certainly impact swallowing and incapacity. You can bleed, from that too. And so that could not be good. So everything in moderation. I would say alcohol in moderation probably won't have a significant impact on swallowing. But high levels, significant consumption can certainly impact swallowing as well as other things. So
are there certain foods that are highest risk for choking?
Not in a normal swallow function individual. I would say that a lot of my patient population, if there is no significant deficit, they may or may not have had radiation. A lot of radiated patients, though, are drier, and patients that aren't well hydrated and have dry mouth and things like that are drier. And so they may have swallowing difficulties, which are a quick fix with just being hydrated. So I would say if there are foods that would cause difficulty to a normal, patient that has no other deficits, then staying hydrated, it would be like the breads, a steak that's not moist. Just the tougher, drier foods can cause some difficulty in some patients. And then, either make it moist or drink more water would be the solution for that. I always tell my patients to sop their biscuits up with gravy if they have swallowing issues, and then tell their primary care doctor that I didn't say that. So
That might just be from being a Memphis person.
Right, exactly. Exactly. That is a fact.
We have just a comment here. Somebody commented and said that they love that you impart humor in your slides. So that's nice. The next question is age a factor in the effectiveness of swallowing interventions and therapy?
That is a good question. So age is a factor in the effectiveness of swallowing. As far as the therapy is concerned, that's an interesting question. I do have patients that are challenging, you know, in the geriatric population, let's just say, because they can't remember the strategies. And so that's hard because, you know, they may show some promise in the therapy session, but oftentimes those strategies require practice and implementing them. And, you know, they have it in them, you know, half the battle is wanting to swallow and wanting to be dedicated to it. But if they have, you know, some cognitive impairment, it makes it a little bit challenging to be successful in the therapies. As far as interventions are concerned, if it's a plumbing issue, I clean the pipe and it works. And so surgically, not usually, but therapy may become a challenge in that regard. And oftentimes, you know, the deficits are more neurologic and do require therapy more so than surgery. And so that does become a challenge, particularly for our speech therapists. But that's a great question.
Next question we have is chewing gum something that should not be done if there are difficulties swallowing?
I would say you're not swallowing the gum, but if you do have a risk of aspiration, I mean, we all do, right? I mean, gum is a mindless thing. I fear my children chewing gum for that reason because they're not paying attention. And so I don't allow them to chew gum. But yeah, if there's a risk of swallowing deficits, it's kind of one of the harder things to successfully remove if there was an episode of aspiration. So I would shy away from that. An Altoid, you know, because that melts in the mouth, might be a better alternative. You know, but aspirating gum would not be fun for anybody to deal with, especially if there are deficits in swallowing. So I probably would tread lightly with the gum and maybe do like a mint or something like that melts fast, like the Altoid.
So this person says that they have trouble swallowing pills or capsules for medication and wants to know if there's any suggestions to help them with that issue.
So I would probably get a swallow study if possible. If there's a PCP, or you could see me and we can get a swallow study. Sometimes when patients come and see me, I tell them to bring the pills that are causing them difficulty. And then we do that in clinic swallow where we could see what's happening with the pill and kind of address it in that way. I've had patients that needed to take their blood pressure medication or cardiac medication and can't cut it in half. So if you can maybe talk to your primary care doctor to see which pills you can crush and which pills can't be crushed. And if there's a different formulation with the pills that can't be crushed, that could be helpful as well. But yeah, pill dysphagia is common, and sometimes it's fixable. The quick and easy fixes are to kind of crush the medication or put them in applesauce or, you know, pudding or anything like that, if they're crushable. If they're not crushable, then finding an alternative is a solution. And if we can do something clinically that we see or find that can be treated in whatever capacity, we can do that too to optimize it. But yeah, I would talk to the primary care and maybe get a test to see where the issue is for sure.
The last question we have here is this person says, I'm a laryngectomy survivor. Are there any physical exercises that can be done to help me improve my swallowing?
That's a great question, and congrats to you for that. That's great news. A lot of my patients are total laryngectomy patients, and regarding swallow strengthening exercises, it all depends. And again, I tried to teach a patient techniques for swallowing therapy and realized very quickly that I'm a surgeon and I'm not a therapist, so I don't want to step on my therapist's toes, because they do what they do so well. But to do what they do well, they need to know the physiology of where the deficit is. So like there's tongue-based exercises, because laryngectomy patients could have any level of the swallowing be an issue. So if there's weakness in the tongue base, they give you tongue-based exercises where you tuck the roof of your mouth and you swallow while you touch your tongue to your teeth. And there's a bunch of other ones as well, depending upon where the deficit is. If there's weakness in the level of the throat or the pharynx, they may give you some posture exercises. They may tell you to tuck your head up so that you can facilitate gravity working in your favor, because as a laryngectomy survivor, you're really dependent upon gravity to help get the food go down too. If there's a blockage, that's where I come in and we can fix the blockage. If there's a spasm, we could help with Botox into the reconstructed food tube to help with the spasm. So it all depends upon where the deficit is. As far as just, I guess, prophylactic exercises, I'm not aware of any per se, but I would, happy to talk offline too. You can send me an email and we could see if there's anything that that my speech therapist can offer in that regard too. But again, congrats for being cancer-free.
Well, thank you again, Dr. Stinnett, for joining us today and taking the time to present and then answer all the questions from our audience. This is going to be our last Sight and Sound Bites for the year. We are wishing all of our attendees and donors and constituents and patients a happy and healthy holiday season, and we are looking forward to connecting with all of you again after the new year. So on behalf of the Eye and Ear Foundation, have a great holiday season. Take care, and we will see you after the new year. Take care. Bye-bye.